This one's not a preterm baby. It's a baby, but I guess I don't exactly know how it wasn't better than it. But you know, that's why pediatrics is so good. Which one's the preterm? Yeah, fairly clear, right? So this is not to scale. The one on the right looks as long as the other one or even longer, but that's because it's not to scale. The one on the right is actually significantly smaller, shorter, leaner, smaller than the one on the left. So when they are born preterm, the problem is not just that they are small, right? They have an entirely different, not entirely, we are all Homo sapiens, so we share a lot of the same physiology, but they have a very different physiology. They have a set of different medical problems that they are prone to. So in neonatology, it's one thing that's different from say adult medicine is that there are these 4 or 5 different sets of patients that you can see, in the sense that we have, for example, it's not unusual to see a 10 times weight range from 500 grams to 5 kilos. And the extreme premature babies have one set of problems, the less preterm babies have another set of problems, and the term babies have a different set of problems. Post-term babies often meconium aspiration syndrome, pulmonary hypertension, and other kinds of problems. So very kind of varied populations. But preterm babies are the ones that are at highest risk of poor outcomes. And that's not just death. Death, of course, is the worst outcome we can think of, right? But there are, really bad outcomes other than death also, like severe neurodevelopmental impairment that can happen to these babies. So prematurity is something that is definitely better prevented than treated, but also happens to be one of the most difficult things to prevent. Nobody has really cracked the code for that. So, so then the next best thing we can do is manage them correctly so that they have good outcomes. So this one is, so I think this is what scale looks more like, probably a bit more accurate. The one on the left is 39 weeks and 3.2 kilos. The one on the right is 28 weeks and 900 grams. So what we're going to talk about is how prematurity affects survival and how they are different, how preterm babies are different from term babies, and how we can, what problems do you expect to see in these preterm babies. We have another topic also in driver and growth restriction. So I think we can finish both in 1 hour. There used to be different topics, but they were combined for some reason. So you know the definitions already. This is just a recap of what you already know. Preterm babies are born before completing 37 weeks. And you know this, right? Less than 28 weeks, they're extreme preterm. You don't need to remember all this. But late preterm is important to remember, 34 to 37 weeks. Because in India, at least a large chunk of preterm babies are born at this gestation. And they were called, at one stage, they were called early, they were called near term. Until a few years ago, they were called near term babies, which gave the wrong impression that they are almost term. They are preterm babies. So to reflect the fact that they are actually at significantly higher risk of problems, the terminology was changed to say late preterm. And then, after that there is term and post-term, and term is divided into 3 effects here. So I'm sure you can get the presentations later. You already know this birth weight based classification, but there are significant limitations to it. The major advantage of this is what? This classification, WHO uses it, a lot of us use it. What's the major advantage here? Why would we use this when we know gestation is the main predictor of outcome? Like, I have 2 classifications, one based on weight and one on gestation. Gestation is? Yeah, of course. Birth weight is so easy to calculate. It's almost impossible nowadays for a baby to be born and not have a birth weight at least taken in the first day of life at some nearby place. If nothing else, shopkeepers' balance will be available in a nearby place and you can weigh the baby. Fairly accurate, right? So weight is very easy to measure. Gestation can be very tricky, especially if it's an unbooked mother, for example, or if she's unsure of dates, she had irregular cycles, many other issues could happen, right? So gestation can be very tricky. Even to this day, we sometimes struggle a little bit with gestation. We recently had a baby where we had to, think about it for some time before we could assign a gestational age. Weight is very straightforward, and it does correlate to outcome to some extent. So this classification is still very useful. But mortality primarily depends on gestation more than birth weight, and this is why prematurity is so important. It is the number one cause of under 5 deaths. And remember, this is we are mainly talking about deaths in the first 28 days of life, neonatal deaths, and it is the number one cause of all under 5 deaths. In the first 5 years, the number one cause of death is death of preterm babies, and that too within the first 28 days of life. So it's one of the toughest problems to tackle if we are trying to reduce under 5 deaths. More than 1 million deaths a year. So if you have 100 deaths due to, say, some new variant of flu, it will be huge. 1 million deaths every year, and it's been going on for a long time. Almost never in the news. More than 1 million deaths actually. And India, of course, partly because of our population and partly because we have a higher rate of prematurity due to multiple reasons: maternal malnutrition, other things, health access, hygiene issues. But anyway, we won't go into the reasons. But India actually has the largest number of preterm births. You can see the difference between India and China. China also has approximately the same population, right? So, almost the same population right now. But we have so many more preterm births. And these are some of the reasons, not all the reasons, some of the reasons for prematurity, multiple pregnancy. And you can see why some of these can be very difficult to prevent. We said that prevention is better than treatment for prematurity, but many of these can be very difficult to prevent. Multiple pregnancy is unfortunately becoming more common, if anything, because of assisted reproductive techniques. Previous preterm delivery is a risk factor for preterm birth. Cervical incompetence, short cervix. There are some treatments available, progesterone and other things, but it's still not very satisfactory. Sometimes there are maternal indications for which, so you could say that it's iatrogenic in that case, in the sense that we had to take the baby out to save the baby or save the baby mother. Maternal infections can cause, so chorioamnionitis will stimulate uterine contractions and the baby may be born prematurely. And in the majority, unfortunately, the cause may not be identified. So that's partly the problem. If you don't know the cause, how do you find the treatment? So when the baby is, so that baby, the 28-weeker, 28-weeker you saw in the first slide was not just smaller. So the physiology is different. Like I said, the organ systems are very immature. So they have a different set of problems, mainly deriving from that. So the respiratory system, for example, if you think of your lungs as kind of like an inverted tree with leaves, when you have a preterm baby, the alveolar phase of lung development actually starts at 36 weeks. Before that, they have alveoli, but very few. So if a baby is born at 26 weeks, that baby doesn't have alveoli, right? Imagine that. So they have acini and things like that, so they can have gas exchange. So it's compatible with life, but they have no alveoli. So it's like a tree, but without the leaves, right? So you can imagine how much less surface area would be available for gas exchange. So they have smaller lungs, fewer alveoli, And in addition, the surfactant system hasn't matured yet, so they have deficient surfactant, and that OP liquid is important in keeping the alveoli open, the airways, smaller airways also open, and that also is a problem. And on top of that, and this is a difficult problem to tackle, because they have respiratory distress, we have to mechanically ventilate them. And normally when we breathe, it's negative pressure ventilation. But when you put a baby on a ventilator, it's positive pressure ventilation. You're pushing air into the lungs. You can cause injury, inflammation, but you can't avoid it. And then if you cause more injury, there is more inflammation. You may have to use higher pressures, and then it kind of becomes a vicious cycle, right? So it's mechanical ventilation is kind of a necessary evil to save these babies, but it can cause injury also. And then you end up with more problems. So, of course, respiratory distress syndrome is something you have already heard about. That is number one problem for them. But because, like we said, infection may be the cause of prematurity, there could be ascending infection, for example, from the vaginal tract, chorioamnionitis. The lacquer also may be infected, and baby already may be born with pneumonia. So, congenital pneumonia is fairly common. And because of multiple factors like this inflammation and ventilator-induced injury, there may be a chronic lung disease of babies called bronchopulmonary dysplasia. And then there is the infection risk. They have an immature immune system, but they also have multiple other risk factors that predispose them to infection. So, for example, you and I have this thick layer of skin. Well, some have thicker skin, right? Politicians, but we have stratum corneum, right? So we have an impervious layer of skin which protects us from bacteria outside, right? We live in a sea full of microorganisms, but they can't get in. But when a 26-weeker is born, that baby has no stratum corneum. So imagine how that is. The baby's stratum corneum hasn't developed yet. So it's like having a patient, for example, with 100%, I don't know what they call it, burns, superficial burns, 100% superficial burns, or something like that, They don't have the top layer of skin. So, in addition, these are the sickest babies, so we have to do procedures to them. We have to put in lines to give nutrition. We have to put in a ventricular tube for ventilation or other things. So, we do more procedures, more handling because they are sick, and that puts them at higher risk also. So, even if you take the best care, they still will be at much higher risk of infection. And we do take good care. NICU, the neonatal ICU has been the hand hygiene champion in JIPMER for, as far as I can remember, definitely in the last 3 years, the official champion. So, but in spite of that, we have a higher rate of infection than many other units, right? We boast about it. So, the gastrointestinal system is again immature, right? They have an immature gut. So now imagine this baby was inside the uterus, the mother was eating for the baby, digesting it. Take protein, for example, broken down into amino acids, transferred across the placenta in the right proportions at something like 4 grams per kg per day, right? The baby does not have to do a thing, right? And now this baby is born, and we have a baby with an immature gut, and we have to give this enterally. And even now in normal situations, enteral intake is, not 100% of what you give, and then there is specific dynamic action and other things. The baby has to spend energy to digest and absorb it. And when the intestine is immature, the secretions, the enzymes and other things, everything's immature, right? How do you maintain this nutrition? These babies are at different sets of problems, different kinds of problems. One is there is this difficulty in feeding the baby. They are not ready to swallow correctly, and they may be at higher risk of aspiration. So sometimes we have to often put in feeding tubes, feed them by tube, later switch to palatal feeds, then to breast feeds, and so on. They often have regurgitation of feeds, and nurses have to be more patient, feed them more slowly. It takes a different kind of mindset to work in the NICU with babies. Then we have a higher risk of infection. Like I said, the skin is immature, same way the gut mucosa is another barrier, right? We have bacteria in the gut normally, but we all don't get septic. again immature among these babies. The tight junctions are immature, so they have translocation of bacteria from the gut also into the bloodstream. They are again at risk of infection because of that. They may end up with necrotizing enterocolitis, which can be pretty bad. Some babies may lose their entire gut or die because of necrotizing enterocolitis. The entire gut may become necrotic, or they may perforate and have peritonitis. And it is a serious condition, and we still have a few deaths every year because of that. Not too many, fortunately. And then poor growth, because of reasons I already mentioned. It's very hard to keep up with the kind of nutrition the baby was getting in utero. It's very hard to keep up with that ex utero. In the cardiovascular system, the normal transition may not take place in preterm babies, and we often have a patent ductus arteriosus, which can cause problems because it's a left-right shunt. Babies may end up with heart failure. We often have to treat it medically and very occasionally surgically. Their myocardial function is also, and their myocardial reserve is also less. So if they get infection, they may go into a different kind of septic shock sometimes with prominent myocardial dysfunction and other problems. Most important is probably the nervous system outcomes, right? So the brain, I mean, most people would pick that as the number one most important organ in the body, right? So they have a very fragile germinal matrix which surrounds the ventricles, and there is a layer of blood vessels under it. So with very little connective tissue support. So even some rough handling could potentially cause a bleed into the ventricle or into the surrounding brain. So they are at higher risk of intraventricular hemorrhage or intracerebral hemorrhage. They have later on they may develop white matter abnormalities called periventricular leukomalacia. And of course, if they have jaundice, they are at higher risk of blood ingress, which you can clearly imagine they have an immature blood-brain barrier. Bilirubin is more likely to cross and cause injury, right? And of course, the anti-seizure mechanisms also have been developed, so they are at higher risk of seizures also. And again, neurosensory, eyes, right? Blindness is fortunately become rare because we now have effective therapy for this condition called retinopathy of prematurity. They are in a relatively hypoxemic state in utero. Does anybody know what's the saturation of blood going to the brain when the baby is in utero? What's our saturation right now? Like if you put a pulse oximeter on me, approximately what would it? Yeah, probably it would show something like 98% or 99%, right? In the fetus, the blood that's going to the brain is only about 65% saturated, which is fine in the fetal period. They do have adaptations that keep them fine, right? And then they are born into this relative state of plenty of oxygen after birth, and sometimes we give supplemental oxygen also. And they can, the hyperoxia drives many things. And it has to do with vascular endothelial growth factor also. But anyway, the end result is that there can be excessive blood vessel growth into the vitreous from the retina, and it may bleed and it may cause retinal detachment, and ultimately in severe cases it may cause blindness also. So retinopathy of prematurity is a problem, and its main risk factor is oxygen therapy. I would say main risk factor is prematurity. Second most important risk factor is probably oxygen therapy and mechanical ventilation. And less important, but again to keep in mind, hepatic renal issues. Everything is different. So drug dosages will be different. Drug half-lives will be different. Anybody knows the half-life of caffeine in neonates? We give caffeine, you know that. In newborn babies, we give caffeine to prevent apnea of prematurity. If you drink a coffee, you can barely make it through one lecture, I'm sure. Right? Depends on the lecture, maybe. But right, depends on who's lecturing, maybe. I don't see anyone asleep yet. But let's see. We are only like 20 minutes into it. So, caffeine half-life is very short. in adults. I don't really know how much it is. Can you imagine? It must be in hours, I'm guessing. How much is it in units? It's about 4 days in a 28 weeker. The 28 weeker you saw has a half-life of caffeine of 4 days, like 96 hours, right? Half-life, I'm talking about reaching half the level, right? So what I mean to say is if you give a loading dose of caffeine today, 4 days later the baby may still have a therapeutic level of caffeine in the blood. So it's very different. It's not just a small adult or a small child. They are very different. So we have to be considerate with, for example, the dosage of aminoglycosides or other things. We have to consider jaundice and other problems more carefully. And you know some of these already, so I'm just going over this. These are the very common problems that preterm babies have. Hypothermia, they have less fat reserves, less brown fat to burn through, less glycogen stores, they have less insulation from fat, they have a higher surface area to body weight ratio. They are prone to infections, other illnesses, which means more handling. Hypoglycemia is another risk. Hypocalcemia, metabolic acidosis, very common. They often lose more bicarb from the kidney, so they may have metabolic acidosis. We use incubators for the smallest babies. This is the same baby, but this one's inside an incubator. I think the first one was in a radiant pump. Okay. So that's about preterm babies. I think that's kind of a broad outline of what preterm baby problems are. And the other topic we have is fetal growth restriction. I think we should be able to finish this well in time. Today morning I was talking to one group of here, kind of some of you, about fetal growth restriction. So again, these are twins. These are twins. The one on top is a girl, one below is a boy. No, sorry, the one on top is the boy, the one below is the girl. So it's many months ago. I think more than a year ago. But again, that is not to scale. So this is the scale really. There is actually a centimeter scale stuck on the. Can you see that? I kind of used that to, rescale it. It's not a very useful scale because the wall is curved, but you can't use it to measure anything, but you can use it to rescale photographs. So anyway, you can see the discrepancy. They are twins. They are the same gestation, right? One happened to have severe growth restriction. So I don't know if it was a boxing match, who would you put the money on, right? Not the boy, I think. Right? So clearly there is a lot of discrepancy here. They were dichorionic twins with significant discrepancy. So what we are trying to discuss is the main consequence of fetal growth restriction, and actually it can have more, different kinds of consequences than you can. Short-term consequences are well known, and most of you are already aware of it, but there can be long-term consequences also. India is again top when it comes to growth restriction, but we'll come to that. We will also go through the management of growth restricted babies. So this is a simple definition of fetal growth restriction. It's actually that's all you need to remember. Fetal growth restriction is when the growth potential of the fetus is below its genetic growth potential, right? So that means in small for gestational age is different, you know that already. Small for gestational age is weight less than 10 centile at birth, right? So for example, if a baby with Down syndrome is growing just below the 10th centile, that is technically not, although we still often call it intrauterine growth restriction, it is really not fetal growth restriction because that baby is growing to its genetic growth potential, right? Which is lower than that for normal babies, right? With, without trisomy, right? So no obstetrician is going to intervene and take out the baby and add prematurity to the baby's other problems, right? You understood? But if let's say let me give you another situation. Father, mother, both are 6 feet tall. First ultrasound, baby is growing fine. And at 30 weeks, the mother develops hypertension. Next ultrasound, baby is from 90th centile, baby has come down to 75th centile. Then the next ultrasound, 50th centile. Then the next ultrasound, 25th centile. So the obstetrician thinks there is a risk and delivers the baby. Now the baby is born at 25th centile. Is this baby SGA? Small for gestational age? No. The baby is about 10th centile, right? But does this baby have fetal growth restriction? Yes. So they are different things. Just keep that in mind. Because you know from previous ultrasounds that this baby was destined to be somewhere along the 75th or 90th centile, but was born at 10th centile or 25th centile, right? Because of what happened in between. The mother had pregnancy-induced hypertension. So when we know that, we can. So usually growth restriction nowadays, fetal growth restriction is nowadays based on at least a couple of ultrasounds in utero, and obstetricians really want to know whether this is really SGA or fetal growth restriction, because fetal growth restriction usually indicates some problem that they may need to do something about, right? So it may indicate that the baby's situation in the uterus is somewhat precarious, and unless they deliver the baby, there may be a risk of intrauterine death also. If there is severe uteroplacental insufficiency, severe growth restriction, they may terminate the pregnancy to save the baby, right? They may weigh the balance, they have to weigh it always. What is the risk of the baby boy being born premature versus the baby, staying in utero and risking death in utero? So the obstetrician's job is harder than ours. They have to decide for both mom and baby, right? And it's usually based on 2 ultrasound, based on in utero growth. But you can also make clinical diagnosis after the baby is born. So it's not that like in that photograph you saw, clearly you could see many clinical features of growth restriction that we have discussed earlier, and we'll come to that, right? So not everybody has ultrasounds. Even even today we see women coming without ultrasounds antenatally, and the baby is born, brought to an ICU, and we diagnosed fetal growth restriction retrospectively just by looking at the baby. So it's not. I'm not saying that you always need ultrasounds, but nowadays when in places with good healthcare systems, you would diagnose it before the baby is even born based on ultrasound growth parameters. So fetal growth restriction is of course a major cause. Actually, I would say this is a very important, and from a societal perspective, significantly preventable cause of low birth weight. It is I would say in some ways more preventable than prematurity. This incidence is quite high, 25 to 35% in developing countries. In our NICU, about a third of the babies admitted have growth restriction, which is very high. For perspective, in Western societies, this will be less than 10% or so, right? And this can affect the kind of society we have many years down the line, and I'll come to that. I think I promised the morning batch, I'll tell them what that means. So there is a higher mortality, of course, but there is also higher morbidity. Higher mortality, and that will come to that, but there is also short-term and long-term morbidity. So the causes may be related to the mother, the baby, the fetus. So you already know most of this, right? The most important cause is mother. Most common would be probably some kind of uteroplacental insufficiency, typically because of pregnancy-induced hypertension. Maybe the mother had diabetes. In India, malnutrition is still quite rampant, and that may be a major cause. Very often we can't identify other causes. Maternal medical disorders, less commonly maternal smoking. The placenta may be abnormal. Sometimes, of course, there are intrauterine infections, genetic causes, other problems in the baby. We won't go into this. Anyway, has medicine people talk to you about leptin? No. Anyway, we won't go into this for now, but maybe we can come back to it later. The problem is that this is why there is a long-term issue with this, right? So when we have, there are some periods in development when, suppose I have poor growth as a fetus and I'm born with low birth weight because of that, right? And then I'm fed very well. I will catch up and I will attain my normal weight. And I may even attain more than normal weight. In fact, I may be at higher risk of obesity. But the damage is already done in that first few months and years. And I can't fix it when I'm older. And this is very tragic, right? I may do all the right things, but still die of myocardial infarction and when I'm 45 because of something that happened that was not in my control, right? I mean, eat the right diet, do the right exercises, walk a mile every day, whatever, right? And still have adverse consequences because of what happened. And the worst part is that some of these effects are transmitted across generations. So there is a transgenerational effect also. Has anybody heard about Barker hypothesis? You have, many of you have heard about it, right? So what is that about? Yeah, so yeah, you're right. So Barker's hypothesis was about fetal origins of adult disease, including hypertension, diabetes, and things like that, right? So his original observation was that in England, because they have birth registries, they can track, right? So they have the birth weights already. So babies born with low birth weight, even if they were term, born with low birth weight, were much more likely to die younger of, what now we sometimes call the metabolic syndrome, like, diabetes, cardiovascular diseases, stroke, that kind of problems. So, obesity. So that was the beginning of, that thought process about maybe some of these have to do with the intrauterine growth. And by now we know that this IUGR and then subsequent feeding patterns can predispose them to type 2 diabetes, obesity, dyslipidemia, and later on maybe cardiovascular disease, coronary artery disease and all that. So this is the reason why it's so important as a country also. And I'll tell you a story later about a natural experiment that happened during the Second World War. There are two kinds of fetal growth restriction that you know about, symmetric and asymmetric. Symmetric, you know what happens. You typically see in, for example, torch infections or chromosomal abnormalities where the head is small, the baby's length may be less, and the baby's weight is less. But asymmetric typically means that there is, let's say, uteroplacental insufficiency, and the fetus's body will try to preserve the blood supply to the brain at the cost of other organs. So the body may grow less, but the brain will still be preserved, initially at least. So they may be born with a relatively normal looking head, but otherwise small looking baby. That's what you saw in the first image also. The baby's head was relatively big looking, but the body was quite small. So then you get what we call asymmetric growth restriction, typically with later insults like pregnancy-induced hypertension. But if it is a very long-standing insult, uteroplacental insufficiency due to some, let's say, placental abnormality, you can get symmetric growth restriction even in those conditions. So there the head size is relatively normal and length is also usually normal. That is because the brain sparing effect. So this is what they look like. I'm not sure what happened to the slide, but anyway. So this is what they look like. So this is the same baby. You can see the head looks relatively fine, but the baby looks very lean. There is clearly lack of subcutaneous fat. It's not very clear here, but the ribs are visible. There are these, wrinkled, loose skin folds in the arm and actually also in the thigh. It's not seen here because of the diaper. You can see the wrinkled skin. Looks like an old person's skin. It looks somewhat dry, sometimes flaky, with crinkling. They have less fat everywhere, including periorbital fat, so sometimes their eyes may look more widely open and kind of gives this alert old man appearance. They have, of course, ponderal index and how it's calculated. So the weight is on top and the height is below, and the height is cubed. So because the weight is lower, but the length is relatively preserved, you get a low ponderal index. Right? They have decreased lean body mass also, which means skeletal muscle size and the fiber number is also less. Oh yeah. Okay, and then there are these short-term complications, some of which you know about. Stillbirth we already mentioned, they are at risk of in utero death and they may be stillborn. So obstetricians may sometimes deliver them prematurely also to prevent that stillbirth. They are at higher risk of perinatal asphyxia. Imagine if there is uteroplacental insufficiency and you have to go through labor. The uterus is contracting and you are already in a compromised situation. There was just barely enough coming across the placenta and now the uterus starts to contract. This baby is definitely going to be at higher risk of asphyxia, right? Especially during vaginal delivery. So there is a higher risk of asphyxia. They are at higher risk, like preterm babies, they are at risk of hypothermia, hypoglycemia, hypocalcemia. These babies, very often there is uteroplacental insufficiency and a state of chronic hypoxemia in utero, which stimulates erythropoietin secretion in the fetus. So they often have a higher red cell mass. They may be polycythemic and that can cause hyperviscosity syndromes. They are at higher risk of respiratory distress. And like we said, there is a brain sparing effect, right? So that means blood flow is diverted to the brain. Away from what? Away from the splanchnic circulation and other things. So the gut has been relatively ischemic in utero. And after birth, when we start to feed the baby, they may be at higher risk of necrotizing enterocolitis also, like preterm babies. And to some extent, childhood outcomes also may be affected. Growth and development both. Growth means final height, head circumference, and development, of course, higher risk of cerebral palsy or cognitive impairment. So this is what we were talking about, Barker hypothesis, right? So I'll let you read that. They had higher death rates from cardiovascular disease. Who knows about the Dutch famine already? Nobody? Okay. So the Dutch famine was an unfortunate natural experiment. There are many natural experiments which let us learn from it, which we don't want to happen, but they happen and then we learn from it, right? The next best thing we can do is learn from it. Like for example, in Fukushima there was a nuclear event, right? So after that, we didn't want it to happen, but we can learn about the consequences from it, from what happened. For example, that's a country with a good healthcare system where everybody has good healthcare records. So we can, for example, look at the malformation rate in that area before, during and after, right? That's possible in a country like that. So the Dutch were still are among the richest countries, and they are also actually very well nourished. I'm sure they are among the tallest people in the world. I think the average male height is 6 feet. That's the median height. So they are among the tallest people in the world. Fairly well nourished, healthy people, rich people. And towards the end of Second World War, and this happened towards the end, when Germany finally got to them and actually put them under strict ration also. Food was severely rationed. So I think even pregnant women were getting something like a couple of slices of bread, right? So a day, right? So there was severe malnutrition among pregnant women also, all pregnant women in the country during that period, right? So which means many of these babies, who were in utero at that time, had significant fetal growth restriction, right? This was a country which did not have that problem before. And this was towards the end of World War. So I think it lasted about a year, the siege, right? And after a year it was lifted by the Allies, and after that again there was plenty of food to eat, right? Right? So all the babies subsequently were okay, but these babies were born later who had significant growth restriction, and of course they had plenty of food to eat as children. So we had plenty, then poverty, then plenty again. So that gave people a good opportunity to study what happens to these children that is different from before and from after. Right? You have two comparison groups, before and after. So it's very easy to find out if these children who were in utero at that time are behaving differently, and they did behave differently, right? When they grew up, they were at higher risk of hypertension, atherosclerosis, coronary artery disease, and stroke and other things, obesity, other problems. So basically, says that that period of poverty followed by a period of plenty when they are fed very well, and we still don't know how to prevent it. If an growth restricted baby is born, what would be the best nutritional strategy to prevent all these long-term problems? We don't know. And that was not the only problem though. So this is clearly a problem, right? Because like I said, we are the IUGR capital of the world, and we have a lot of maternal malnutrition still, like a lot of teenage girls in school still malnourished. So this means that our future for the next few decades is problematic. Even if we cure that problem today, right? The children who are born now, when they are growing up to be adults, they'll still be at risk of atherosclerosis and hypertension, diabetes, and all those problems, right? And that's not the only problem. From the Dutch cohort, one other thing that came about is that if this woman was pregnant, let's say her daughter had growth restriction, that daughter's daughter also was growth restricted, or son, right? So there was a transgenerational effect. So what we are doing now could have effects. It may take a couple of generations to fix this problem, right? So there is some urgency to addressing these problems in the community, like maternal malnutrition. So feeding young women in school, young girls in school, may be a good strategy for a nation's future, right? Because these are the kids who are going to be. So these effects can last a couple of generations. They are clearly not genetic problems. Right? Starving can't alter your DNA to a large extent, but many of them are epigenetic problems and seem to be, at least across one generation, it seems to be transmitted. So, in other words, if a woman has a growth restricted child today, that child's child could also be at higher risk of growth restriction. Seems to be it. So the Dutch cohort, there are two generations, third generation, or probably a fourth generation now. So we know this already, that there is a transgenerational effect. There was another famous siege during the World War, which was the Stalingrad siege, that I think lasted much longer and many more million people died. But there this problem was not there, and you can look up why. Okay, so anyway, it's a very important problem. I mean, it's not as simple as you think. It's not that we treat the hypothermia and hypoglycemia and the baby is fine after that, right? It has significant long-term consequences. Not all of them will be at higher risk. So if you were born IUGR, don't panic, right? I was also IUGR. Well, I should probably panic. I'm like in the 45, 46 right now, so maybe I should, but you don't have to. So it's still not a very high risk. Right? But it's just that compared to children who were born AGA, we are at higher risk. Ideally, we should diagnose it based on antenatal ultrasound, because we want to pick it up early and if possible try to intervene early. In ultrasound, usually they check the head circumference, the abdominal circumference, femoral length, and often they see a discrepancy, especially the abdominal circumference is a very good indicator. Particularly because the liver becomes smaller, less glycogen, less fat in it, it becomes smaller. So the abdominal circumference goes down first. The head circumference will go down only much later. So the abdominal circumference will be the most sensitive one. That will go down first. And then the amniotic fluid oligoamnios will set in, so the amniotic fluid index you can follow. And later on, and when there is severe uteroplacental insufficiency, the placental vascular resistance will be high. So you can get Doppler flow abnormalities like absent end-diastolic flow or reversed end-diastolic flow. By the time fundal height is affected, it is pretty obvious that there is growth restriction. That is less sensitive anyway. Very often still we diagnose after the baby is born, and especially with unbooked pregnancies, we see the child and recognize that there was very growth restriction. So there is really no one specific management. In general, for the mother, we treat the underlying cause, if it's pregnancy-induced hypertension or diabetes, we try to control that. We keep monitoring the baby more closely than you would for a baby without fetal growth restriction. And the timing will depend on the obstetrician's choice to some extent. If the baby is at high risk of intrauterine death, they'll of course deliver. And sometimes because that baby is still not term, there may be neonatal facilities required. Neonatal intensive care facilities required. In the labor room, these babies are at higher risk of asphyxia and other problems. So if there is a baby with significant fetal growth restriction, we'll usually request a senior resident to attend. Very rarely even a consultant to attend. So just to make sure that the initial resuscitation is done right. We have to pre-warm the warmer. That is true for all babies, but these babies are at particularly high risk of hypothermia. And if it is very severe growth restriction, we'll shift the baby to an ICU to monitor better. But even otherwise, if they are in the ward, we'll still need to monitor them for hypoglycemia, especially the first couple of days. We will have to check for polycythemia, usually at 2 hours and 12 hours. We'll do a PCV. If the PCV is more than 65% in a venous gas, that's in a venous blood sample, that's polycythemia. If the fat cell volume. So the hematocrit is what neonatologists check more often than hemoglobin. Of course, frequent breastfeeding. In general, we give on-demand feeds, but the most growth restricted babies, we may have to give scheduled feeds to prevent hypoglycemia. And it's usually important to tell the mother that she has to feed at night also. Even if the baby doesn't demand it, wake up once or twice in the night, 2 night feeds at least, to make sure there is no hypoglycemia at night. So overall, preterm babies has prematurity is still the major cause of death, more than intrauterine growth restriction, and it is the most important cause of under 5 mortality. They have a different set of problems than term babies. They can have some of the term baby problems also, but they have many unique problems that can happen in only preterm baby. They are at higher risk of abnormal neurodevelopment, including neurosensory problems like visual impairment and deafness. Fetal growth restriction has major short and long term adverse consequences that we discussed about already.